Cancer treatment for hundreds of patients, including children, has been disrupted in the Eastern Cape yet again after the health department failed to pay suppliers of essential chemotherapy drugs. Doctors facing impossible choices have been forced to decide who receives chemotherapy and who doesn't, with some oncology units reportedly left with just a single vial of this potentially life-saving medication. Let's bring in Dr Mthandeki Xamlashe, the Deputy Director General for Clinical Services in the Eastern Cape Health Department. Dr Xamlashe, thanks very much indeed for joining us. The heartbreaking thing is that this is not the first time this has happened in the Eastern Cape insofar as the treatment of cancer patients is concerned. What's going on?
Good afternoon, Michelle, and thank you for having me, and good afternoon to your listeners. There are a number of challenges that are a bit complex. Some are avoidable, some are difficult to avoid. On the main show, this is not necessarily limited to Eastern Cape. You may have heard about it in other provinces. There are national challenges with availability of certain molecules, of certain oncology medicines. These molecules are imported through Section 21 permits from SAPRA because they're not manufactured locally. Now, what has been happening in the global supply chains, which most people are aware of, affected the supply of these drugs to our own suppliers. That's basically has been the main problem that affected the availability of medication in the country, not only in Eastern Cape.
Okay,
that's one part of it.
Hold on, let's hone in on that first point then, Dr. Xamlashe. So you're saying that it's not about the department's failure to pay for cancer treatment, but rather a shortage of medication.
I'm coming to that. Yeah, I'm coming to that, Michelle. That's just one part. I wanted to give a full picture. The other part of the problem is our payment behavior in terms of honoring accounts of certain suppliers. We have not been great in that area due to certain fiscal constraints that were confronted with as a province. Companies do accommodate us, believe you me, they do stretch their credit limits in order to accommodate us. And despite that, we sometimes struggle to honor those. And sometimes some of these companies, they suspend our accounts. It's something that we've been dealing with for 2 months, and we have now come to a solution in respect of those. We have set aside 200 million rand, and we have given certain guarantees to those accounts, and those accounts are now open, and those companies are beginning to supply us. There may be a few of them that have started delivering only 2 weeks ago. That caused a lot of conflict. But what I want to emphasize, and most importantly, is that our clinicians, as you mentioned earlier on, faced with the difficult choices, do not allow anyone to go home without getting alternative medication, which only challenge would have been exposing people to new side effects that they're not used to, but still treating the cancer as effectively. So we really thank our professionals and our oncologists in different parts of the province who have continued to sustain the supply of care of our patients despite the challenges. And we are now working on a long-term solution in terms of payments of accounts, which is something that is within our control. We've set aside the money, as I've stated earlier on, but we're also looking at new credit arrangements that will ensure continued supply of cancer medicines to our patients.
So two things, Dr. Xamlashe. Can you point us to the information that talks about a shortage of the molecules, as you say, used for the production of cancer drugs? I'm just doing a quick Google search of it, and I can't find any information that says that there is that challenge in South Africa. And then to the point that you just made about patients receiving alternative medication, reports tell us that hundreds of patients have already been turned away without receiving treatment.
No, patients are not turned away without treatment. Patients are given alternative medications. Most of these drugs, they will have certain classes, your class 1, class 2, class 3. Of course, class 1 would be the best one to give to a patient at any time, but class 2 would also be as effective, sometimes with more side effects. And class 3 will probably be not the best choice to give to a patient. So patients are never turned away, really, without any medication.
That's what the Human Rights Commission says, Dr. Xamlashe, and they've done investigations into this issue in the Eastern Cape.
Yeah, they worked with us. We gave them the information, and we don't hide anything from Human Rights Commission. They interview us, they interview our doctors.
Well, they say patients have been turned away, hundreds of them.
Not really, Michelle, that's certainly not the case. Not the case at all. We do have challenges, but we don't turn patients away. We interact with these doctors. We know them by their own names. They phone us when they're confronted with a particular challenge, and we always resolve it on the spot and they work with us as management to make sure we resolve this challenge which exists. The issue of payment of suppliers is a problem, and it is man-made, and we are solving that problem as a province, despite the challenges that there. And our suppliers are cooperating, and they are supporting us a great deal.
And then the first part of my question, pointing us to that information that says we have a shortage of the molecules needed to manufacture cancer treatments?
Yes, certain suppliers do not have adequate stock to supply us as a department. And the reason
Can you name those suppliers, please, Dr. Xamlashe, as we'd like to follow up on the story?
Yeah, but we know them by name, but we can give you their details for you to verify that offline. I'm not sure if it will impact on their business reputation, but we have information which we'll share with you. We can give you the specific name of those companies, but they're also dealing with those issues, And it's not only cancer drugs, by the way. It's also other drugs that we import, that we don't manufacture locally that are affected by these global supply challenges. So we are also like any other commodity. If there is instability in global supply challenges, we also get affected. It happened with medical equipment, and we know with our cancer machines, which we know. So the drugs are also affected in the same fashion. We're glad to share with their permission their names so that we can make contact with those companies. We know them by name. I know them sitting here because I talk to their CFOs almost every week.
Yeah, I mean, if this is the case and we are running short of cancer medication because we don't have what's needed to make it, to manufacture it, then certainly I think that's a story that needs following up on. And our producer for Daytime Update, who's been in contact with you for this interview, Sinikethiwe Hlanze, will get that information from you. But desperate doctors tell us that they've been forced to make impossible decisions about who gets cancer treatments and who doesn't. Sometimes having one vial of chemotherapy and having to make that kind of decision. Are those kinds of stories true?
Yeah, those stories are true. As I made a reference earlier on to the various classes of drugs, you may get a drug, for example, called oxybutynin, that may be used for treating breast cancer, which may be the best drug. You may have one vial for it, and it may be enough for one patient, for example. But you always have class 2 combinations that you give to patients to have the same clinical effect, but a little more uncomfortable for the patient. We still use those. So they are right when they say sometimes they may have one vial or sometimes nothing in terms of your best choice of drugs. The issue is that of best choice of drugs to give for a particular patient. Clinicians are experts. They know what is best for their patients, but at times they only have to give what is good and better, not necessarily the best for their clients under the circumstances. It's a situation that's regrettable, and we will make sure that these things do not continue and you come up with sustainable solutions. We would appreciate a follow-up discussions because this subject is far more complex. Because the more we screen patients at primary health care, which is what the country is doing, the more we pick patients that have got cancer. And then there's a sudden surge in demand for these cancer drugs. Not only us, but also the suppliers may not be prepared for the increased demand for these drugs, So it's a bit of a more complex, complicated situation, but it's something we're working together and collaborating with our own suppliers that we are prepared to overcome. It is not a bad thing because it also shows that we're screening more patients in primary health care, diagnosing them earlier on, and then the demand for medicine is much higher. Obviously, ours is to make sure we supply those medications. So there are good aspects of it. There's also bad aspects of this situation.
And yeah, absolutely. It means we're screening more people. But you will know, Dr. Xamlashe, that, when you go for a checkup with your doctor and that dreaded C word comes up and the doctor talks about cancer, it is a devastating blow to patients. And this break in treatment surely doesn't just impact their physical health, these patients, but also must have a massive toll on their mental health and well-being.
True. We offer comprehensive care to our patients. It's not just about drugs. We have social workers, we have psychologists who deal with this, who are supporting clinicians to make sure that there's a good outcome and there's support to all the patients. But the drugs are very key in terms of stopping, the spread of the cancer or the growth of the cancer itself. So we don't take away the importance of those drugs, but we offer all those other services. Definitely, it is devastating, I admit, that even when you're given your best drug and suddenly the doctor says, I'll give you a second choice because the first choice that I've been giving you for 6 months is out of it. That is definitely not good news, and it gives patients more desperate. We may code science and try and convince them these drugs, when they are combined, they're as effective as the first one. It will be a very difficult thing to do. So we're working very hard to make sure we adhere to what we would have prescribed for the patient as the best drug. We're working very hard, and we're going to win the battle.
So Dr. Xamlashe, how far are we now in paying outstanding bills insofar as specialist medicines, including medicines for cancer treatment, is concerned? I understand there would have been monies owing from the last financial year in the province as well. How far are we in settling those outstanding funds?
We have paid 400 million already out of the 600 million that was outstanding for most pharmaceutical companies. And the last time I checked 48 hours ago, in terms of cancer medication, 2 companies that had suspended our accounts have opened them, and we're not owing them huge amount of money. It was 1.2 million and 400,000. So those companies, 48 hours ago, they are now starting to deliver those medicines to our hospitals, and our patients are still going to get the best care that we've been giving them all along.
All right, Dr. Mthandeki Xamlashe is the Deputy Director General for Clinical Services in the Eastern Cape Department of Health. And Doc, as promised, you will come back to us and give us an update on the situation in your province. Thanks for joining us.